Aguille mantiame Agüeruko señe Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeruko señe Toiko subi pura hey Albu arito bebé Aguille mantiame
Ya se acuarahu Dobu aveima O cañen borahu Doye veima Tapere Me hueca tu de que Te quiere o yo quiere Ya jamón burbe Ya se acuarahu Dobu aveima O cañen borahu Doye veima Tapere Me hueca tu de que Te quiere o yo quiere Ya jamón
Aguille mantiame
burbe
Agüeruko señe Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeruko señe Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeruko señe Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeruko señe Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeruko señe Toiko subi pura hey
O cañen
arito bebé Aguille mantiame Agüeruko señe Toiko subi pura hey
O cañen
arito bebé
Doye veima
Agüeruko señe Toiko subi pura hey arito bebé To bebé taisarambi perbeture Señe agui añanduva pura hey To putanye epote de yurupe Apocabupe se añua Rei potaro e yerurente Peisajina Paraguay Paipuque la Emiliano Ta ipuque la Yambay Yajamino ñondive Yero que Torbu ape yajesape koe Aguille mantiame Agüeruko señe Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeruko señe Toiko subi pura hey Albu arito bebé Aguille mantiame
Ya se acuarahu Dobu aveima O cañen borahu Doye veima Tapere Me hueca tu de que Te quiere o yo quiere Ya jamón burbe Ya se acuarahu Dobu aveima O cañen borahu Doye veima Tapere Me hueca tu de que Te quiere o yo quiere Ya jamón
Aguille mantiame
burbe
Agüeruko señe Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeruko señe Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeruko señe Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeruko Rico subí pura hey, arito bebé. Pura hey. To bebé tai sarambi perbeture. Senyi awi anyanduva pura hey. To petanya epote de yurupe. Apocabupe se añua. Rei potaro e gerurente. Peisajina Paraguay. Paipuque la Emiliano ta ipuque la Yambay. Yajamino ñondive yero krenape. Torbe ape yajesape koe. Aguille manteame agüeruco señe toico subí pura hey. Albu arito bebé. Aguille manteame agüeruco señe toico subí pura hey. Albu arito bebé. Aguille manteame.
Ya se acuaraje todo aveima o cañen borajú doye veima ta pere de hueca tunde que te quiere o yo quiere ya jamón burbe. Ya se acuaraje dobe aveima o cañen borajú doye veima ta pere de hueca tunde que te quiere o yo quiere ya jamón
Aguille manteame
burbe.
agüeruco señe toico subí pura hey. Albu arito bebé. Aguille manteame agüeruco señe toico subí pura hey. Albu arito bebé. Aguille manteame agüeruco señe toico subí pura hey. Albu arito bebé. Aguille manteame agüeruco señe toico subí pura hey. Albu arito bebé. Aguille manteame agüeruco señe toico subí pura hey.
O cañen
Arito bebé.
doye veima ya se
Agüeruco señe
dobe aveima
pura hey.
o cañen
Arito bebé.
doye veima
Agüeruco señe rico subí pura hey. Arito bebé. Pura hey. To bebé tai sarambi perbeture. Senyi awi anyanduva pura hey. To petanya epote de yurupe. Apocabupe se añua. Rei potaro e gerurente. Peisajina Paraguay. Paipuque la Emiliano ta ipuque la Yambay. Yajamino ñondive yero krenape. Torbe ape yajesape koe. Aguille manteame agüeruco señe toico subí pura hey. Albu arito bebé. Aguille manteame agüeruco señe toico subí pura hey. Albu arito bebé. Aguille manteame
ya se acuaraje dobe aveima o cañen borajú doye veima ta pere de hueca tunde que te quiere o yo quiere ya jamón burbe.
hey, halbu arito bebé, awi yemante ame, awe uko senye, pero subi pura hey, halbu arito bebé, awi yemante ame, awe uko senye, pero subi pura hey, halbu arito bebé, awi yemante ame, awe uko senye, pero subi pura hey, halbu arito bebé, awi yemante ame, awe uko senye, pero subi pura hey, arito bebé, awi yemante ame, awe uko senye, pero subi pura hey, arito bebé, awi yemante ame, awe uko senye, pero subi pura hey, arito bebé. To bebé tai sarambi pelveture senye awi anyanduva pura hey. To petanye epote de yurupe apokavupe se anyua. Rei potaro e yerurente peisajina Paraguay. Paipuque la Emiliano ta ipuque la Yambay. Yahamino nyondive yero knape. Torbu ape yahesape koe. Awi yemante ame aweruko senye. Toiko subi pura hey. Halbu arito bebé. Awi yemante ame aweruko senye. Toiko subi pura hey. Halbu arito bebé. Awi yemante ame.
Yasena kwaraku dobu aveima Okanyin boraku doje uveima Tapere mewe katundeke Te quiere o yo quiere Yahamon buruve Yasuha kwaraku dobu aveima Okanyin boraku doje uveima Tapere mewe katundeke Te quiere o yo quiere
Awi
Yahamon
yemante ame
buruve
aweruko senye. Toiko subi pura hey. Halbu arito bebé. Awi yemante ame aweruko senye. Toiko subi pura hey. Halbu arito bebé. Awi yemante ame aweruko senye. Toiko subi pura hey. Halbu arito bebé. Awi yemante ame aweruko senye. Toiko subi pura hey. Halbu arito bebé. Awi yemante ame aweruko senye. Toiko subi pura hey.
Okanyin
Arito bebé. Awi yemante ame aweruko senye. Toiko subi pura hey. Arito bebé. Yemante ame aweruko senye. Toiko subi pura hey. Arito bebé. To bebé tai sarambi pelveture senye awi anyanduva pura hey. To petanye epote de yurupe apokavupe se anyua. Rei potaro e yerurente peisajina Paraguay. Paipuque la Emiliano ta ipuque la Yambay. Yahamino nyondive yero knape. Torbu ape yahesape koe. Aguille mantiame agüeruco señe toico subí pura hey albu arito bebé Aguille mantiame agüeruco señe toico subí pura hey albu arito bebé Aguille mantiame
ya sea cuaracu todo aveima o cañen boracu doye veima tapere me hueca tunde que te quiere o yo quiere ya jamón burbe ya sea cuaracu doble aveima o cañen boracu doye veima tapere me hueca tunde que te quiere o yo quiere ya jamón
Aguille mantiame
burbe
agüeruco señe toico subí pura hey albu arito bebé Aguille mantiame agüeruco señe toico subí pura hey albu arito bebé Aguille mantiame agüeruco señe toico subí pura hey albu arito bebé Aguille mantiame agüeruco señe toico subí pura hey albu arito bebé Aguille mantiame agüeruco señe toico subí pura hey
o cañen
arito bebé Aguille mantiame agüeruco señe toico subí pura hey
o cañen
arito bebé
doye veima
agüeruco señe toico subí pura hey albu arito bebé to bebé taisarambi pelbuture señe agui añanduva pura hey to putanye epotu de yurupe apukabupe se añua Rei potaro e yerurente peisajina Paraguay Paipuque la Emiliano ta ipuque la Yambay Yajamino ñondive quiero que hape Torbu ape yajesape koe Aguille mantiame agüeruco señe toico subí pura hey albu arito bebé Aguille mantiame agüeruco señe toico subí pura hey albu arito bebé Aguille mantiame
ya sea cuaracu doble aveima o cañen boracu doye veima tapere me hueca tunde que te quiere o yo quiere ya jamón burbe ya sea cuaracu doble aveima o cañen boracu doye veima tapere me hueca tunde que te quiere o yo quiere ya jamón
Aguille mantiame
burbe
agüeruco señe toico subí pura hey albu arito bebé Aguille mantiame agüeruco señe toico subí pura hey albu arito bebé Aguille mantiame agüeruco señe toico subí pura hey albu arito bebé Aguille mantiame agüeruco To bebe tai sarambi perveture Shenye agui anyanduva pura hei To petanye epote de yurupe Apocavupe se anyua Rei potaro e gerurente Peisajina Paraguay Paipuque la Emiliano ta ipuque la Yambay Yahamino nyondive yero khape Torbu ape yahesape koe Aguille manteame Agüeruko señe Toiko subi pura hei Albu arito bebé Aguille manteame Agüeruko señe Subi pura hey, albu arito bebé, aguille manteame, aguille manteame, agueruco señe, rico subi pura hey, albu arito bebé, aguille manteame, agueruco señe, rico subi pura hey, albu arito bebé, aguille manteame, To bebe tai sarambi perveture Shenye agui anyanduva pura hei To petanye epote de yurupe Apocavupe se anyua Rei potaro e gerurente Peisajina Paraguay Paipuque la Emiliano ta ipuque la Yambay Yahamino nyondive yero khape Torbu ape yahesape koe Aguille manteame Agüeruko señe Toiko subi pura hei Albu arito bebé Aguille manteame Agüeruko señe hey, albu arito bebé, aguille manteame.
Gracias a Cuarajú, todo aveima, o cañón borajú, donde el reina, tapere, de hueca tú te quiere o yo quiere, ya jamón bebé.
pura hey halbu arito bebé awi yemante ame aweru kosenye ego subi pura hey halbu arito bebé awi yemante ame aweru kosenye ego subi pura hey halbu arito bebé awi yemante ame aweru kosenye ego subi pura hey halbu arito bebé awi yemante ame aweru kosenye ego subi pura hey arito bebé awi yemante ame aweru kosenye ego subi pura hey arito bebé aweru kosenye ego subi pura hey arito bebé pura hey to bebé taisarambi perveture senye awi anyanduva pura hey to petanye epote de yurupe apocavupe se añua Rei potaro e yerurente paisajina Paraguay paipuque la Emiliano ta ipuque la Yambay yajamino ñondive yero krehape torbu ape yajesape koe aguille manteame agüeru kosenye toiko subi pura hey albu arito bebé aguille manteame agüeru kosenye toiko subi pura hey albu arito bebé aguille manteame
Yasina kwaraku dobu aveima Okanyin boraku doje reima Tapere me hueca tunde que te quiere o yo quiere ya jamón burbe Yasina kwaraku dobu aveima Okanyin boraku doje reima Tapere me hueca tunde que te quiere o yo quiere ya jamón
aguille manteame
burbe
agüeru kosenye toiko subi pura hey albu arito bebé aguille manteame agüeru kosenye toiko subi pura hey albu arito bebé aguille manteame agüeru kosenye toiko subi pura hey albu arito bebé aguille manteame agüeru kosenye toiko subi pura hey albu arito bebé aguille manteame agüeru kosenye toiko subi pura hey arito bebé aguille manteame agüeru kosenye toiko subi pura hey arito bebé aguille manteame agüeru kosenye toiko subi pura hey arito bebé pura hey to bebé taisarambi perveture senye awi anyanduva pura hey to petanye epote de yurupe apocavupe se añua Rei potaro e yerurente paisajina Paraguay paipuque la Emiliano ta ipuque la Yambay yajamino ñondive yero krehape torbu ape yajesape koe Aguille manteame, agüeruco señe, toico subi pura hey, albu arito bebé. Aguille manteame, agüeruco señe, toico subi pura hey, albu arito bebé. Aguille manteame,
Ya será cuaracu, todo aveima, o cañón boracu, donde el reina, tapere, de hueca tunde que.
Muy buenos días a todos. Les damos la cordial bienvenida a este Simposio Internacional sobre Fibrilación Auricular, en el cual contamos con la presencia de distinguidos invitados, como ser el colega, el doctor José Alderete, que en estos momentos está haciendo su especialización en la Universidad de Kioto, Japón, y el profesor jefe del Departamento de Electrofisiología, el profesor Satoshi Shizuta, quien también nos estarán compartiendo los últimos avances en materia de tratamiento de la fibrilación auricular. Realmente nos sentimos muy honrados acá de la División de Medicina Cardiovascular del Hospital de Clínicas, Facultad de Ciencias Médicas, por poder organizar este simposio y compartir con ustedes, como dije, los últimos avances desde el punto de vista del tratamiento, diagnóstico y tratamiento de la fibrilación auricular, con una universidad tan prestigiosa mundialmente como es la Universidad de Kioto. Están como panelistas el profesor Dr. Omar Centurión, también cardiólogo, electrofisiólogo, especializado en la Universidad de Hiroshima, el doctor Carlos Benítez, cardiólogo intervencionista, especializado en Francia, y el doctor Zapatini, que es Senior Resident del Departamento de Cardiología de nuestra universidad. Dear Professor Satoshi Shizuta, for us it's a great pleasure and honor to have you in this international symposium about atrial fibrillation, and we are very pleased to have you and to share with us the latest update in atrial fibrillation management and treatment. Professor Satoshi is an assistant professor of Kyoto Graduate School of Medicine. He is the head of the electrophysiology department of the Kyoto University. And the professor is very experienced in atrial fibrillation ablation. Actually, he started to do these procedures in 2004, and up to date has more than 3,000 cases done by himself. So he's a large experience in atrial fibrillation ablation, and as I told you, it's a great honor, Professor Shizuta, to have you with us.
It's my great pleasure. Thank you.
Dr. José Alderete, he will start the lecture with the challenging diagnosis of atrial fibrillation. Doctor José.
Ok, muchas gracias. Voy a compartir mi presentación. Está. ¿Se ve mi presentación?
Yeah, very well.
Muy bien. Muchas gracias, profesor Galeano. Es realmente un honor poder estar acá compartiendo con mi jefe acá de Japón, con el profesor Satoshi Shizuta, este simposio internacional sobre fibrilación auricular. A mí me toca desarrollar un poquitito como introducción a su tema, la situación actual de la fibrilación auricular y los desafíos en cuanto al screening y diagnóstico de esta patología. No tengo nada que declarar. Bueno, comenzando un poquitito, ya en 1994 empezaron a salir los primeros resultados del estudio Framingham en relación a la fibrilación auricular, y vimos que tanto la incidencia como la prevalencia de la fibrilación auricular aumentaban a medida que transcurría la edad de los pacientes. La incidencia era bastante alta, sobre todo en aquellos pacientes mayores de 85 años, y esto es algo que se mantiene hoy en día, pero incluso estamos viendo una mayor incidencia de fibrilación auricular a edades mucho más tempranas, probablemente porque estamos diagnosticando mucho más, ya que contamos con mucha mayor tecnología que aquella época. Esta incidencia de fibrilación auricular es mayor hoy en día a la que teníamos 30 o 40 años atrás, y vemos que aumenta notablemente a partir de los 65 años. Por lo tanto, la prevalencia global de fibrilación auricular hoy en día se estima que ronda los 45 a 50 millones de personas y probablemente esto esté infraestimado, ya que no contamos con datos muy fidedignos, sobre todo en regiones como América Latina, África. Sí contamos con datos bastante fuertes de Europa y Estados Unidos, pero probablemente esta prevalencia global incluso esté infraestimada. Se estima que el riesgo de desarrollar fibrilación auricular a partir de los 50 años es de 1 en cada 3 individuos. Esto se vio en la población europea. Y las proyecciones de prevalencia de fibrilación auricular realmente son números que asustan. En el año 2010 se estimaba un número total de 6 millones de habitantes en Estados Unidos que presentaban fibrilación auricular. Y se estima que para el año 2050 este número prácticamente va a duplicarse, llegando a 12 millones de personas. Una curva bastante similar es lo que se ve en la población europea, donde se estima que en el año 2010 prácticamente 9 millones de personas tenían fibrilación auricular y que para el año 2050 este número también se va a duplicar, llegando a prácticamente 17 millones de personas. Por lo tanto, la fibrilación auricular es realmente un problema de salud pública a nivel mundial. Se asocia con una alta morbilidad, con una alta mortalidad, con un riesgo aumentado de 3 veces de mayor mortalidad en estos pacientes y, por supuesto, con unos costos tremendos para el sistema de salud pública. Solamente en Estados Unidos se calcula el gasto anual que conlleva esta patología en 28 billones de dólares. Para tener un poco en cuenta los números que estamos teniendo, en Estados Unidos 9% de las personas mayores de 65 años tienen fibrilación auricular. Esto se asocia la fibrilación auricular a unas 750.000 hospitalizaciones al año, 130.000 muertes anuales y, por supuesto, la complicación más tenida, que es el accidente cerebrovascular isquémico, que se presenta bastante frecuentemente en estos pacientes y tiene peores resultados o peor pronóstico que aquellos casos de accidentes cerebrovasculares de otras etiologías. Por lo tanto, la fibrilación auricular vemos que se asocia a un aumento de la mortalidad de 3,5 veces de aumento de mortalidad, se asocia con un riesgo de accidente cerebrovascular 5 veces mayor que la población general, es causa de un 20 a 30% de los accidentes isquémicos vasculares y 10% de los strokes criptogénicos. Se asocia en un porcentaje muy alto a disfunción ventricular e insuficiencia cardíaca. Esto se ve en 20 a 30% de los pacientes con fibrilación auricular. Conlleva un riesgo de 40 a 60% de desarrollar demencia vascular o un deterioro cognitivo, incluso independiente al desarrollo o no de un accidente cerebrovascular isquémico. Estos pacientes tienen una mala calidad de vida, se asocia a depresión incluso con intentos suicidios en muchos pacientes y, por supuesto, en un aumento de las hospitalizaciones. Los datos del mundo real en Europa nos muestran que al cabo de 2 años de seguimiento desde el diagnóstico, 5% de los pacientes fallecen. La causa principal de muerte en estos pacientes obviamente es cardiovascular y dentro de esto la insuficiencia cardíaca conlleva aproximadamente el 75 a 80% de las causas de muerte de estos pacientes. La mortalidad asociada a la fibrilación auricular tiene mucho que ver con el tipo de fibrilación auricular que presenta el paciente, con un relativo mejor pronóstico para aquellos pacientes que tienen fibrilación auricular paroxística y con un peor pronóstico para aquellos pacientes que tienen fibrilación auricular persistente y permanente. En relación al diagnóstico de fibrilación auricular, sabemos que necesitamos para hacer el diagnóstico un electrocardiograma o, en su efecto, una tira de una sola derivación de al menos 30 segundos que nos muestre un ritmo irregular con ausencias de ondas P. Esto hace el diagnóstico de fibrilación auricular clínica. En relación al screening de fibrilación auricular, hay que resaltar que debemos ser enfáticos en recomendar el screening de fibrilación auricular a todo paciente mayor a 65 años, a los pacientes hipertensos y a los que tienen apnea obstructiva de sueño. No debemos perder la oportunidad en las consultas de realizar una palpación del pulso, una auscultación cardíaca, de controlar la irregularidad del ritmo mientras tomamos la presión para detectar fibrilación auricular silente y asintomática en estos pacientes. Y un screening más intenso y sistemático debemos realizarlo en aquellos pacientes que tienen mayores de 75 años y que están realmente en riesgo de desarrollar accidentes cerebrovasculares. En cuanto a las estrategias, a las herramientas con las que contamos para realizar el screening, tenemos varios tipos y esto varía a lo largo de los distintos países y de las regiones dentro de un mismo país. Tenemos maniobras muy básicas como la palpación del pulso o la auscultación cardíaca, el control del ritmo cardíaco durante el control de la presión arterial. Luego tenemos ya dispositivos un poco más invasivos como los parches cutáneos, el Apple Watch Holter de distinta duración y por último los dispositivos para realizar un screening continuo serían ya los dispositivos implantables, los loop recorders y los dispositivos tipo marcapasos, resincronizadores y desfibriladores. Realmente todos estos dispositivos muestran una alta sensibilidad y especificidad para detectar fibrilación auricular y uno debe utilizar lo que tiene a disposición. Vamos a empezar a hablar un poquitito del screening de fibrilación auricular. Este año, en el Congreso de la Asociación Europea del Ritmo Cardíaco, en abril, fue presentado el estudio Stroke Stop y publicado concomitantemente en la revista Lancet, que estudió pacientes mayores de 75 años y los siguió por 7 años para ver si realmente el screening tenía o no incidencia en la tasa de eventos adversos. Y se vio que los pacientes que realizaron un control de electrocardiograma 2 veces al día por 2 semanas tuvieron una disminución de eventos isquémicos y hemorrágicos, de embolia sistémica, de sangrado mayor o muerte por cualquier causa. En cuanto a los puntos secundarios de este estudio, vemos que aquellos participantes que hicieron un control, un screening sistemático de fibrilación auricular, tuvieron una reducción del 24% del riesgo de desarrollar stroke isquémico en relación a los controles. Por lo tanto, se vio que el screening de fibrilación auricular muestra un beneficio en comparación con el tratamiento o con el cribado estándar, indicando que el screening es seguro y es beneficioso para poblaciones mayores, sobre todo de alto riesgo. Ahora bien, el otro tema que voy a abordar es los episodios de alta frecuencia auricular detectados en los dispositivos implantables. Esto se conoce normalmente como fibrilación auricular subclínica. Es decir, aquellos pacientes que tienen dispositivos tipo marcapasos, resincronizadores, desfibriladores, que no se conocen portadores de fibrilación auricular y están totalmente asintomáticos, pero a la hora de hacer el chequeo de estos dispositivos nos encontramos con estos episodios de alta frecuencia auricular que realmente tienen un impacto también en la evolución a largo plazo de estos pacientes. Y estos pacientes que tienen fibrilación auricular subclínica, solamente detectadas por estos dispositivos, realmente son un grupo muy heterogéneo de pacientes porque la carga de fibrilación auricular en estos pacientes varía muchísimo. Por ejemplo, en este primer caso podemos ver un paciente que tiene episodios de fibrilación auricular relativamente frecuentes, pero de muy corta duración, como podemos ver de minutos, prácticamente 1 a 2 minutos, un episodio por acá alrededor de 10 minutos, con una carga total de fibrilación auricular de menos de 0,1%. Si queremos plantear anticoagulación con este paciente, y probablemente no se beneficiaría demasiado. Sin embargo, otro caso, podemos ver que en un seguimiento de 1 año y medio, este paciente ya presenta episodios un poco de mayor duración, alrededor de 1 hora, 2 horas, llegando casi incluso a 3 horas, pero todavía la carga total de fibrilación auricular es de 0,4%. Si tomamos en cuenta que este paciente es un paciente varón de 66 años, hipertenso, jugador de tenis, asintomático, sin fibrilación auricular clínica, manifiesta realmente la decisión de iniciar o no anticoagulación no es una decisión fácil. Por último, tenemos también este tipo de pacientes en los que encontramos fibrilación auricular en el 12% del tiempo, como vemos acá, prácticamente en un periodo de 2 meses, el paciente estuvo en fibrilación auricular el 100% del tiempo. Entonces sí, probablemente ya estos pacientes se beneficiarían más del inicio de una anticoagulación oral. Siempre es importante no solamente ver el histograma, sino corroborar realmente que estos episodios detectados como alta frecuencia auricular en los dispositivos son realmente episodios de fibrilación auricular, porque podemos tener un oversensing o incluso ruido que el dispositivo puede estar interpretando como episodios de alta frecuencia auricular. Así que siempre es importante corroborar esto y estar 100% seguros de que realmente se trata de fibrilación auricular antes de iniciar un tratamiento. Ahora bien, estos pacientes con fibrilación auricular subclínica tienen un riesgo aumentado de eventos tromboembólicos, pero el riesgo es menor que aquellos pacientes que tienen fibrilación auricular clínica. Ya en el estudio ACERT, publicado en el 2013 en el New England Journal of Medicine, se vio que estos pacientes tienen un riesgo 2.5 veces mayor de presentar stroke isquémico o una embolia sistémica a lo largo del tiempo. Habíamos visto que el riesgo de stroke en los pacientes con fibrilación auricular clínica es 5 veces. En cambio, estos pacientes parecería ser que el riesgo es la mitad. Y si vemos en la tabla de la izquierda, vemos que tenemos tres grupos de pacientes. En azul, los pacientes sin fibrilación auricular. En blanco, los pacientes con fibrilación auricular subclínica. Y en naranja, los pacientes con fibrilación auricular clínica o manifiesta. Y vemos que el riesgo anual de desarrollo de un evento tromboembólico es mayor independientemente del score de CHATS en aquellos pacientes con fibrilación auricular clínica. Pero el riesgo en los pacientes con fibrilación auricular subclínica no es despreciable. También estos pacientes tienen un riesgo estos pacientes con fibrilación auricular subclínica, un riesgo de desarrollar fibrilación auricular clínica a lo largo del tiempo, por lo tanto deben ser seguidos de cerca. En un subanálisis de este estudio ACERT publicado en el 2017, se vio realmente que los pacientes que tienen mayor riesgo de desarrollar un evento tromboembólico son aquellos pacientes que tienen fibrilación auricular subclínica con una duración mayor a 24 horas. Son estos pacientes los que realmente marcan una diferencia a la hora de presentar unos eventos tromboembólicos. En el gráfico de la derecha podemos ver que los pacientes que no presentan fibrilación auricular subclínica, los que tienen de 6 minutos a 6 horas o de 6 horas hasta 24 horas tienen un patrón bastante similar y eso lo demuestran las curvas, prácticamente no se separan. Sin embargo, aquellos pacientes con fibrilación auricular subclínica con una duración mayor de 24 horas sí tienen un riesgo más de 3 veces mayor de presentar un evento tromboembólico a lo largo del tiempo. Bueno, tal es así que sigue la duda sobre estos pacientes que este año en el Congreso Europeo de Cardiología se presentó un estudio sumamente interesante que fue el estudio LOOP, que investigó si la implantación de un dispositivo, de un loop recorder, en pacientes de alto riesgo para detectar fibrilación auricular realmente tenía impacto en la prevención de stroke. Y voy a hablar un poquitito, comentar brevemente sobre este estudio. Este estudio entonces investigó si la detección de fibrilación auricular en pacientes asintomáticos y el inicio de anticoagulación oral en estos pacientes, si se detectaba fibrilación auricular, podía prevenir accidentes cerebrovasculares. Se incluyó pacientes mayores de 70 años con factores de riesgo tromboembólicos y fueron randomizados 6.000 pacientes en una relación de 1:3 a recibir un dispositivo implantable tipo loop recorder, en este caso fue el dispositivo de Medtronic, o fueron asignados a un grupo control. Y se decidió anticoagulación oral en todos los pacientes que presentaban fibrilación auricular con una duración mayor a 6 minutos. Si vemos las características de estos pacientes, vemos realmente que eran pacientes de alto riesgo con un score de CHATS de alrededor de 4. En cuanto al sexo, prácticamente el 50% entre varones y mujeres estaban bien balanceados. Más del 90% de los pacientes tenían hipertensión arterial, más del 15% de los pacientes ya habían tenido un stroke previo, o sea que eran realmente pacientes de alto riesgo. Y podemos ver que los números fueron realmente llamativos. En el grupo con dispositivos implantables, con el loop recorder, se detectó fibrilación auricular en el 32% de los pacientes. Y asimismo se detectó 12% de fibrilación auricular en el grupo control. Es decir, el loop recorder detectó 3 veces más prácticamente fibrilación auricular que los pacientes que fueron seguidos de forma estándar, digamos, con un seguimiento medio de 64 meses. En cuanto a la duración de los episodios de fibrilación auricular detectados en el loop recorder, vemos que el 42% de los pacientes presentaban una duración de 6 minutos a 5.5 horas y solo 16% de los pacientes presentaban una duración de fibrilación auricular mayor a 24 horas. Obviamente, prácticamente el 90% de los pacientes en los que se detectó fibrilación auricular iniciaron anticoagulación oral. Sin embargo, a la hora de ver los resultados, lo que buscaban, la prevención de stroke o embolia sistémica, vemos que si bien es cierto, hubo una reducción de 20% de los eventos en el grupo con loop recorder, esto fue no significativo con una P de 0,11. Si le sumamos a esto el accidente isquémico transitorio, un compuesto de accidente vascular isquémico, embolia sistémica o accidente isquémico transitorio, hubo una reducción del 8%, pero tampoco fue significativo con una P de 0.47. Podemos discutir más adelante en la discusión a qué se debe probablemente estos resultados, una gran detección de fibrilación auricular, pero sin embargo no tuvo impacto a nivel de prevención de eventos isquémicos. Por lo tanto, tenemos nosotros realmente dos grupos grandes de fibrilación auricular. Por una parte, la fibrilación auricular clínica, la que conocemos, la que detectamos en los electros, la que presenta síntomas y un riesgo muy aumentado de eventos tromboembólicos, en los que sabemos que la anticoagulación está bien indicada. El score de chats nos marca realmente el pronóstico de estos pacientes, y tenemos un grupo grande de pacientes que tienen fibrilación auricular subclínica. Son pacientes que están asintomáticos, que detectamos fibrilación auricular de forma incidental o con dispositivos o con algún dispositivo portátil buscando esto, o durante una internación por otro motivo, o durante una evaluación por un stroke. Y realmente en estos pacientes el rol de la anticoagulación todavía no está demasiado claro, tampoco el impacto que pueda tener a largo plazo, si bien es cierto, aparentemente tiene un mayor riesgo de eventos tromboembólicos, pero menor que aquellos pacientes con fibrilación auricular clínica. Las recomendaciones que tenemos hoy en día para manejar estos pacientes con fibrilación auricular subclínica o que se detecta por dispositivos es la siguiente. En aquellos pacientes que tienen episodios mayores de 24 horas, y sí probablemente está indicada la anticoagulación, esto siempre teniendo en cuenta también el riesgo embólico y de sangrado del paciente, también está indicada la anticoagulación, como sabemos, en los pacientes que tienen un chat elevado. Sin embargo, hay un grupo grande de pacientes que se encuentran en el medio, que tienen estos eventos menores a 24 horas o que tienen un score de chats no tan elevados, en los que necesitamos todavía ciertos estudios para tener una evidencia científica fuerte que nos indique realmente cómo proceder con estos pacientes. Actualmente están en marcha dos estudios, que son Artesia y NOA. Estos estudios van a estar listos entre el año que viene, 2022 y 2023, que están justamente investigando si la anticoagulación en este grupo de pacientes con episodio de fibrilación auricular subclínica menor a 24 horas, si los anticoagulamos, si tenemos realmente un impacto o no en relación a los eventos tromboembólicos. Como mencioné, Artesia es uno de ellos. Artesia está investigando apixaban en la reducción de eventos tromboembólicos en estos pacientes con fibrilación auricular subclínica. Como vemos, está incluyendo pacientes que tienen fibrilación auricular de 6 minutos a 24 horas con factores de riesgo para desarrollar eventos tromboembólicos sin fibrilación auricular clínica. El otro estudio que está en marcha, se piensa que estará listo para el año que viene, para el 2022, es el NOA AFNet 6, que está investigando edoxaban en estos pacientes con episodios de fibrilación auricular detectados en dispositivos implantables. Quiero terminar mi presentación con estos mensajes. La incidencia y prevalencia de fibrilación auricular está aumentando de forma global. Se asocia con una alta morbilidad, alta mortalidad y con unos costos excesivos para el sistema de salud. El aumento de la detección de fibrilación auricular ha aumentado en las décadas pasadas, lo que es importante, ya que aproximadamente un tercio de estos pacientes con fibrilación auricular se encuentran asintomáticos y desconocen su diagnóstico. El screening de fibrilación auricular es seguro y beneficioso para poblaciones de riesgo, y necesitamos hacer el screening de acuerdo a los medios que tengamos a nuestra disposición. No existe hoy en día un solo método de screening que podamos recomendar, ya que todos tienen muy buenos resultados en cuanto a la detección de fibrilación auricular. Los episodios de fibrilación auricular subclínica son frecuentes. Los estudios hablan de que detectamos fibrilación auricular subclínica entre un 30 a 50% de los pacientes que presentan dispositivos implantables. Se asocian con un aumento de los eventos tromboembólicos, si bien es cierto, menor que los pacientes con fibrilación auricular clínica, pero hay un riesgo de eventos. Y también se asocian con progresión a fibrilación auricular clínica, por lo tanto debemos seguir de cerca a estos pacientes. La decisión de iniciar anticoagulación oral debemos individualizar basándonos en el riesgo tromboembólico y en el riesgo de sangrado, en la carga de estos episodios que tengan los pacientes, más de 24 horas o menos de 24 horas, y la progresión de estos episodios. Muchas gracias.
Muchísimas gracias, José, por la brillante presentación sobre la detección de pacientes con fibrilación auricular, realmente muy ilustrativo. Y vamos a continuar con nuestro siguiente expositor. We'll continue with our next speaker, Professor Satoshi Shizuta, who is the head of the electrophysiological department of Kyoto University. He's an assistant professor of the Kyoto Graduate School of Medicine, and he is a very experienced doctor in the field of atrial fibrillation ablation. As I mentioned previously, he has started ablation in 2004, and up to now he has more than 3,000 cases. And he will give us a lecture about the indication, advance, and clinical outcome in ablation of atrial fibrillation. Professor Shizuta, as I told you, it's a real honor to have you as our main speaker.
Sorry. Just a moment, please. Okay, I will do again. Sorry. Okay, can you see my slide?
Yes, can we see?
Okay, thank you.
Yes,
Thank you very much, Professor Galliano. It is my great pleasure to talk in this international web conference. Today, I would like to talk about rationale, indications, and advances and clinical outcomes of catheter ablation of atrial fibrillation. Here is my disclosure. And this is number of catheter ablation in Kyoto University Hospital, KUHB. And since I came to this hospital in 2002, it gradually increased. And in recent several years, the number was around 500. But because of COVID-19 pandemic, the number of cases last year was only 374. And this number, 515, 2 years ago, was in Japanese ranking book, ranking 18 in all Japanese hospital, and ranking second in university hospital. The number one is Tsukuba University, but they have 3 catalogs only for catheter ablation, although we have only 1 catalog, and we can use that 1 catalog for only 3 days a week. So I think our 515 cases is pretty good, as our only situation, only 1 catalog. So I'd like to, from here, talk about AFib ablation because regarding AFib and risk of death and stroke and other morbidities was well talked about by Dr. Jose. So AFib ablation started in 1998 after this famous report in New England Journal of Medicine by Professor Heisegel in Bordeaux University, France. And he showed that electrical firings from pulmonary veins cause AFib is located in 90% of cases in pulmonary veins, not other sites. So in this original paper, they tried to eliminate those focuses one by one, but it is very difficult. So soon after, they started pulmonary vein isolation. So as you can see, there is a myocardial sleeves within pulmonary veins, and this part is degenerated according to age, and then started to firing and cause AFib. So burning all around the pulmonary veins, usually 2x2, burning ipsilateral pulmonary veins like this is the main stain of AFib ablation. So AFib ablation is much better than anti-arrhythmic drug in terms of higher arrhythmia survival. There are numerous studies comparing catheter ablation and medical therapy, and this is one of the most famous study, A4 study, published in Circulation 2008. And as you can see, there is a huge difference between the arrhythmia-free survival in RFCA group and anti-arrhythmic drug group. So based on those data, I'd like to show you current indications of AFib ablation in the consensus statements and guidelines. This is most recent consensus statements of HRS, United States, EHRA, Europe, and APHRS, Asia, including Japan. The document was published in Heart Rhythm, Europace, and Journal of Arrhythmia. This is official journal of APHRS and JHRS, Japan Heart Rhythm Society. And as you can see, AFib ablation for paroxysmal AFib and symptomatic AFib patients with paroxysmal AFib is class 1 indication as a second-line therapy when at least one antiarrhythmic drug is not effective to suppress AFib. And for persistent AFib, it is class 2 indication, and for long-standing persistent AFib, it's class 2B indication, because the longer the AF duration becomes, the lower the success rate becomes. So for long-standing AFib, catheter ablation is class 2B indication. And the first-line therapy for symptomatic AFib, when the AFib is paroxysmal, the indication is class 2A. So even without the trial of anti-arrhythmic drug, you can perform catheter ablation in high volume centers or when you are an experienced operator. So usually in Japan, we don't try anti-arrhythmic drugs for paroxysmal AFib patients. In more than 50% of patients, we perform catheter ablation for symptomatic paroxysmal AFib patients without the use of anti-arrhythmic drugs. And also for persistent AFib, it's class 2A indication, and long-standing persistent AFib, it's class 2B indication. The only difference is for paroxysmal AFib, as a first-line therapy, it becomes class 2A, not class 1. In other conditions, including congestive heart failure, older patients older than 75 years old, HCM, young patients younger than 45 years old, tachycardia syndrome, and athletes with AFib, in those situations, the indication is all class 2A indications reasonable. But for asymptomatic AFib, the indication is class 2B, that means controversial. But in Japan, many catheter ablation for asymptomatic AFib is now performed. Maybe it may be too much, but I will talk about this later. So next I would like to talk about actual method of PV isolation. So I said mainstay of the AFib ablation is pulmonary vein isolation, and when the method is RFCA, radio frequency catheter ablation, binding like this, epicyclical superior and pulmonary vein is a common method. But it is not so easy because the anatomy of left atrium and pulmonary vein is different from patient to patient. It has very large variability like this. This is common trunk. This is also common trunk. Many kinds of anatomy. So in this kind of situation, 3D mapping system guiding the location of ablation catheter becomes very, very important. So I would like to talk about 3D mapping system. There are three 3D mapping system now available in worldwide. And the most popular 3D mapping system is Cardo of Johnson & Johnson. In this Cardo system, we take 3D CT, marginalized CT prior to the ablation. And during ablation, we first perform PV angiography. And looking at both images, it's mirror images, left, right. And we adjust the position of this CT images in the 3D mapping system. When after the position of this map is adjusted to the exact position, we don't have to see fluoroscopic images. We can only all we have to do is look at the 3D mapping system. Let me show one cases. This slide shows exactly a same moment of one patient. This is 3D images, and this is fluoroscopic images, mirror images. And in fluoroscopic images, the ablation catheter goes up like this. Goes like up this. Exactly same moment was recorded in 3D mapping system like this. Like this, exactly same. So we don't have to see fluoroscopic images, just look at the 3D mapping system. So recently the radiation dose is very, very low in AFib ablation. Some operators, European and the US operators, try to make their fluoroscopy time to 0, but I'm not so aggressive to make the fluoroscopy time to 0. I think it is too much, maybe. So I will show you very good educational cases. I always use this in the lecture for medical students in Japan. This is the exact moment, recording exact moment of electrical firing from pulmonary veins leading to AFib. Adenosine was injected to induce AFib. Adenosine is usually used to terminate PSVT, but it accelerate vagal nerve, activate vagal nerve, and then as a rebound, sympathetic nerve becomes active. So AFib can often induced by adenosine injection. So green light is LSPV signals, yellow light is LIPV signals, and white and light blue is RSPV signals. And sinus rhythms, and AFib firing was occurred from pulmonary veins. Again, sinus, and AFib. Can you see which APV fired and caused AFib. Yes, green is first, yellow is second, and a little bit later, RSPB was potential was observed. So due to adenosine injection, AV block, only P wave, no QRS, P wave, no QRS, and firing started here from LSPV, leading to intra-PV fibrillation, and also outside a pulmonary vein, whole atrium is atrial fibrillation, and in body surface ECG, you can see F wave, no QRS because of transient AV block due to adenosine. So because we thought that LSPV is most arrhythmogenic, we started to isolate LPV, left side LP pulmonary vein first, burning all around the pulmonary veins on the 3D mapping guide. Then finally, we successfully isolated LSPV and LIPV simultaneously. Look at the video. Still there are signals and disappeared. So at this time, LSPV and LIPV was simultaneously isolated. Okay. Next, we isolated RPV potentials, RSPV and RIPV, and then also again RSPV and RIPV signals disappeared at the same time simultaneously. So RSPV and RIPV was isolated. After successful isolation of both LPVs and RPVs, looking at the RSPV, isolated RSPV, something happened like this. Multiple firing occurred, but heart was not affected. Firing, but not cardiac rhythm was not affected because RPV and LA was already disconnected by catheter ablation. So multiple firing, but stable sinus rhythm. This is why we isolated pulmonary veins, and this clearly showed that pulmonary vein isolation is effective in this patient. So next, I would like to talk about acute complications and long-term arrhythmia-free survival after AFib ablation. This is second worldwide survey published in 2010, and the ablation itself was performed between 2003 and 2006 in 16,309 patients from 182 centers. And as you can see, the rate of death was 0.15%. The rate of the cardiac tamponade was 1.31%. Arterioesophageal fistula, mostly lethal, was 0.04%, and stroke occurred in 0.23% of the patients. And the long-term success rate, including the inpatients with ADUs, was in paroxysmal AFib, 84%, in persistent AFib, 74.8%, and in long-lasting persistent AFib patients, 71%. 84% for paroxysmal AFib is reasonable, but maybe this persistent AFib and long-standing AFib, the success rate may be too high, probably because of inadequate follow-up and also short duration of follow-up. So let me show you our single center experience published in International Journal of Cardiology in 2017. And this was our relatively initial experience. We have more than 3,000 cases now, but this is 1,206 patients from 2004 first case to 2015. Mean follow-up duration was 5 years, and complete follow-up rate was 99.3%. And mean age of the patients was 64.3 years, and chest VASC score was mean was 2.0. This slide shows acute 30-day adverse outcomes and deaths occurred Fortunately, in this population, did not occur. And arterial esophageal occurred in one patient, stroke occurred in one patient, or both 0.1%. So although cardiac tamponade was a little bit high because this population include very, very initial experience of AV fibrillation, it is 1.7%, but now it is around 1% or so. Half of them were made by young doctors, and half of them were made by myself. But anyway, it is now around 1% or so. And regarding the long-term arrhythmia-free survival after first ablation, it is like the 60% at 10 year and percentage 30% at 10 year. But after the last ablation, second or third or fourth ablation, regarding paroxysmal AFib, it's quite good. It's over 80% at 10 years. And regarding persistent AFib, the success rate is not so bad, 70% at 10 years. So the long-term outcome is pretty good. So here, I'd like to talk about Dr. Jose in Kyoto University. He came to Kyoto University 1 year ago, October last year, and he is very, very smart and wise, and he is very aggressive to learn AFib ablation, and we every day perform AFib ablation 3 cases per day, so it ends at 7 or 8 o'clock, but every day he will in catheter from 8:30 to the last of the procedure. So and also he's aggressively doing his research. His research team I gave him is the 10-year clinical outcomes after AFib ablation, and it was presented at ESG 2021 in this August, and it's now preparing for submission because our new database was completed 1 week ago. This was his presentation slide in ESC 2021. And as you can see, there are 500 patients who have more than 10 years follow-up. And as you can see, after first procedure, the maintenance of sinus with the rate of was not so good, around just about 40% at 10 year, and regarding percentage AFib, it's around 25% or so. But after last procedure, regarding paroxysmal AFib, it's nearly 90%. And also for persistent AFib at 10 year, the success rate was 60%. So I think this data is pretty good, and we would like to submit this data to major journal or in the field of EB cardiology. So next, I would like to talk about advances in the ablation system. So now, irrigation catheter is available in Japan. It became available in 2010, 11 years ago. And the initial type was, the hole was only 6. But in the current type, the hole is 56 holes. This is a Johnson & Johnson carotid catheter, but this system is using this system. Thrombus formation rarely occurred. And also, 5 years ago, contact force sensing catheter became available. This was very, very good. contact force, how many forces, grams, the catheter is pushing the tissue, we can see every seconds. Let me see the real case. So now this is contact force, and at the X period it is 10 gram, but in inspiration period it becomes 25, 30, because we are burning a roof. So when breathing, the roof becomes down and the contact force becomes higher. Burning the tissue between 10 grams and 30 gram, maximum 40 gram is ideal. So this is very, very good for safety reason and also for efficacy reasons. Even when the operator is very experienced, sometimes the catheter contact was only 5 grams or so, and sometimes it becomes 70 grams or so. If the contact force becomes equal or higher than 80 grams, it can perforate left atrium. So catheter contact force catheter is very, very good. It's some breakthrough. And also now we can use ablation index. Ablation index is determined by contact force and power of the RF energy and duration of RF energy application. And not all the calculation formula is open. Some of them are in black box. We don't know the details of the calculation, but this is very, very useful. So this is a very famous study, close study, published in Europace recently, and they compared conventional method versus contact force guiding ablation, index guided ablation. They burned more than 550 around the pulmonary veins, and in contact force only guided approach, they burned all around with 10 grams. And the result was, acute results were ablation index guided ablation was associated with shorter procedure time, and in long term, it was associated with higher arrhythmia free rates, 94% versus 80% with statistical significance. So let me see, I'd like to show you the real case. When I burn here, the contact force is a little bit, maybe too strong, but it's okay, lower than 40. And at the beginning, it's not available, but it start, and now it's 397, and this is pink, but this is almost white. But after it reaches 400, it becomes pink, like this, okay? And after it reached 600, we burned very thick sites. We usually burned until 600. And when the ablation index reached 600, the color will become red. See this here. And now it's become 600. So we ablate under the ablation index guide. So I also introduce you novel 3D mapping system Rhythmia, because this is very effective to eliminate atrial tachycardia. When atrial arrhythmia relapse after AFib ablation, it is not necessarily AFib original form, but it is very often switched to atrial tachycardia, regular tachycardia. But 5 or 10 years ago, it was very difficult to eliminate that atrial tachycardia regulatory circuit. And this Rhythmia 3D mapping system has high quality artificial intelligence program, and also it has high quality mapping catheter, basket catheter. It will never take any noises. So using this catheter, using other 3D mapping system during 21 minutes, only 362 point was recorded, but it showed nothing. But during same 23 minutes, 21,556 points were determined using this rhythmia system, and the excitation looks going around here. So this mapping is high density and high resolution, and each point the annotation of the ECG, which point is the excitation point of excitation period of the point is automatically determined by artificial intelligence. This is very fractionated ECGs at this point. It can be here, it can be this largest point, but the artificial intelligence annotated here this sharp potentials. The algorithm is mostly in black box, so we don't know the details, but it is very, very accurate. So this is my first case using this rhythmia mapping system. And the pulmonary vein is already isolated. This is second session, and this is atrial tachycardia. And going from right to left in the left atrium, and going outside, this is CS, coronary sinus, and RA and LA, from right to left, and going outside CS. Right atrium, left atrium, from right to left, and this is slow conduction down. So burn here, then finish. And without using rhythmia mapping system, it is very difficult to realize this tachycardia circuit, because the potential of this point is the amplitude is 0.08 millivolt. And usually using other mapping systems, it is difficult to map the area with the amplitudes of equal or less than 0.1 millivolt because of noises. If there are noises like this, if there are noises, there is no noise at all, one beat, no noise at all. But if there is noise like this, artificial intelligence cannot determine, nothing. But because of very high quality basket catheter, never taking noises, then this kind of ECG can obtain in every point, and this kind of map can be made by artificial intelligence. So this is my educational video made by Boston Scientific 4 years ago. And this was third session, and atrial tachycardia, regular tachycardia, and now mapping is going, and then finished. And finally, this atrial tachycardia was mitral atrial tachycardia, going clockwise, rotating clockwise around the mitral annulus. But in the second session, we made block line here, but it was okay. The block line was okay, but the excitation passed through the CS outside the heart, and then conducted through here and rotate. So it is it is nonsense to burn endocardium site. We should burn within the CS. So I put the ablation catheter to the shears like this, and pull back and place here and bond here, start bond here. The tachycardia will stop within 15 seconds. Please look at this. Atrial tachycardia. Start burning 1 second, 2, 3, 4, 5, 6, 7. It will turn at 13 seconds, 9, 10, 11, 12, 13, and terminated. So one burn and tachycardia was terminated. And I thought this was finished. Everything was finished. But spontaneously, another tachycardia occurred. So I started mapping again. And finally, I realized circuit. It was rotating around the anterior wall counterclockwise, and the slow conduction zone is here. Not slow conduction, and slow conduction zone is slowly conducted here. So this is a critical point. So I place the ablation catheter to this point, this point, and bond. And at this time, this atrial tachycardia terminate at 5 seconds. So start 1, 2, 3, 4, and terminated at 5 seconds. And then all tachycardia was terminated, and he is free from any tachycardia for 4 years. This case was 4 years ago. So this third time session was very, very successful. So next, I'd like to talk about balloon technology. The most frequently used balloon is cryoballoon now. First generation balloon was available since 2007 in Europe and US, and second generation balloon was become available worldwide, including Japan, since 2014. And this is a famous fire and ice trial comparing RF and cryoballoon, and the long-term results was identical. The recurrence rate was 36%, but it may be too high because the patients were all paroxysmal AFib patients. So maybe cryoballoon was partly first generation, and RF energy not using contact force sensing catheter, so very high recurrence rate. But anyway, RFCA and cryoballoon was had identical long-term results. But even if the results are same in long term, the most attractive point of cryoballoon is short duration of procedure. 3 to 4 minutes freeze, 3 to 4 minutes, 3 to 4 minutes, 3 to 4 minutes, then 15 minutes and done. So usually using cryoballoon ablation, left side pulmonary isolation, left side ablation, all pulmonary isolation will finish within an hour from skin to skin. So when using RF, it will take 2 hours also. So it is very, very attractive. So 7 years ago, our cases jumped from 350 to 467. And the main reason was, I think, the introduction of cryoballoon, I think. So how about the long-term results of our result and our Kyoto University hospital and also our colleagues' hospital. All hospitals are high-volume centers, and 1,143 patients were enrolled in this registry. And the arrhythmia-free rate at 1 year was only 86.9%. That means recurrence rate was only 13.1%. So very, very good. And when the results of the study of the was compared according to centers. There was no difference among the 3 centers. This was already reported. This was a relatively famous paper published in 2017. And this gray bar center is high volume center, very high volume center. And when RFCA is used, this high volume center has very high arrhythmia-free rate at 2 years, 80%, but other centers it's much lower. But when cryoballoon was used, all the 24 arrhythmia-free rate was almost same in all centers. So cryoballoon will not depend on the operator's skill or experience, and it has high reproducibility. And as a result, comparing cryoballoon and RFCA, cryoballoon was associated with significantly higher arrhythmia-free rate, and the risk of recurrence of arrhythmia was, the hazard ratio was only 0.47, approximately half. So the conclusion of the study was cryoballoon seems to be less operator dependent and more reproducible than RF for paroxysmal AFib patients. So we can use laser balloon too, and in the very near future, we can use 3rd generation laser balloon, but I don't think we should use this laser balloon because it will take a long time, and when esophagus is near the laser balloon, we cannot isolate PVs. So I don't want to use laser balloon. I have never used laser balloon. I'm very satisfied with cryoballoon. Anyway, we have several future and upcoming new technologies, but among them, pulse-field ablation is most promising, I think. Pulse-field ablation use electroporation, and thresholds to electroporation is different from tissue to tissue. Myocardium is very sensitive to electroporation, but red blood cells, vascular muscle endothelium, that means esophagus, arteries, and blood flow is 4 times, the threshold is 4 times higher, and regarding nerve, the threshold is 9 times higher. So using this energy, we can selectively burn myocardium. So shaping like this, we can isolate pulmonary vein, and cryoballoon can burn and isolate pulmonary veins, but it can also injure the anterior wall of esophagus. RF energy also can injure and burn the anterior wall of esophagus, but using this pulse-field ablation, esophagus was quite intact. Recorded in MRI. In animal model, in LA posterior wall, esophagus was completely transmurally ablated, but esophagus was completely intact. This is also histological analysis at 35 days post pulse-field ablation in swine model. And looking at here, myocardium is completely eliminated, but you can see blood flow here, and also you can see completely intact nerve here. So it can selectively eliminate myocardium. So this slide shows durability of pulse-field ablation immediately after and 3 months after, no change at all. So we thought this is amazing technique, and this is promising. Maybe the success rate will be over 90%. But recently, the results of 3 studies, combining 3 studies, was published, and surprisingly and disappointedly, the arrhythmia-free survival at 1 year was only 78.5%. I showed using cryo alone, the arrhythmia-free rate was 86.9% at 1 year, but this is very, very initial experience in very selected centers. So after learning curve of the operators, I think it will be around 90% or so. And also tissue selective nature of this energy is very, very attractive. So I'm very looking forward to using this new system. So next, finally, I'd like to talk about whether catheter ablation of AFib will improve long-term clinical outcomes in terms of cardiac functions, mortality, stroke, and heart failure hospitalization. So first, I'd like to talk about cardiac functions after AFib ablation in patients with concomitant heart failure. This is a famous study published in 2004, 17 years ago. Amazing. 58 patients with NIH class 2 to 4 heart failure and LVEF 45 equal or less than 45% were included. Age 56 years old, average EF 35%, LVDD 60, not so large. And the results were amazing. LVEF was almost normalized. And also LVDD was almost normalized from 60 to 55, LVDS also. This was the first report. And after 4 years later, a randomized study was published. This is PUBCH study, symptomatic AFib, NMRC equals 234, 23 heart failure, LVS EF equal or less than 40%. And they randomized 81 patients to PV isolation or IV node ablation followed by CRT, biventricular pacing. That is very aggressive rate control. And they compared the cardiac function. And as you can see in the IV node and biventricular pacing, ejection fraction as well as 6 minutes walk test has no change at all. But in PV isolation group, ejection fraction markedly improved and also 6 minutes walk test markedly improved. This is our case, and 66 years old male, persistent AFib for 2 years, NMH class 2 heart failure. The ejection fraction was only 27%, LVDD was 58, not so large. And after AFib evaluation and post 1 year, as you can see, LVEF normalized to 63% and LV diastolic dimension normalized to 49 millimeter. And after 10 years after PUBCH study, famous CASTLE study was published, and primary endpoint of all-cause death or worsening heart failure hazard ratio was 0.62 for ablation as compared with medical therapy with p-value of 0.007. And also regarding all-cause mortality, the hazard ratio was 0.53, almost 50% reduction with a p-value of 0.01. And looking at the subgroup analysis, NYHA class 3 heart failure patients and also patients with LVEF less than 25% had no difference between compared with medical therapy. So maybe sickest patients may not benefit from AFib ablation. I'd like to show you our single center experience. 280 patients undergoing AFib ablation who had coexistent AFib, defined as prior heart failure hospitalization, and estimated average systolic blood pressure 40 equal or more than 45, and CRBNP level higher than 200. And after catheter ablation, LVEF, diastolic function, E prime, E dash, and BNP level, left atrial dimension, mitral regurgitation, all improved at 1 year. And when looking at the LVEF, all patients had LVEF equal or less than 50% at baseline, and it improved at 6 months, and it further improved between 1 year and 3 years. And when patients were divided to LVEF equal or less than 40% and LVEF 41 to 50%, the late improvement in LVEF occurred just in LVEF equal or less than 40%. Predictors of improvement in systolic function at 1 year in patients with baseline ejection fraction 50% equal or less than 50% was persistent AFib, LVDD 55 millimeter equal or less than 55, or MR, or recurrent AF. That means persistent AFib, relatively not so large LV, and also maintenance of sinus rhythm is important for the improvement of systolic ejection fraction at 1 year. So mortality, stroke, and heart failure hospitalizations. Swedish Health Registry and several non-randomized studies show that AFib ablation was associated with lower risk of ischemic stroke as well as lower mortalities. After several studies, Castlave studies clearly showed the mortality benefit in the randomized style. And after that, but this in Castlave studies, very narrow spectrum of patients were enrolled. Ejection fraction equal or less than 35%, and all patients had prior ICD. So in this patient, so after the Castlave study, Covenant trial enrolling more general patient population was published. But because most patients wanted to receive catheter ablation, the enrollment was very, very slow, and patients with very benign nature was enrolled, so leading to lower event rates. So because of those low enrollment, lower event rates, and the study design was changed during the study. Primary endpoint was changed from all-cause mortality to a composite of death, stroke, bleeding, and cardiac arrest. And also initially 3,000 number of patients to be enrolled was changed to changed to 2,200s. And also what is important is substantial crossover in medical group. Those patients received catheter ablation because they are presumably very, very unhappy. Medical therapy was not enough for those patients. On the other hand, 9.2% of patients did not receive catheter ablation, but this was okay, I think, because they did not receive catheter ablation, presumably because they were not so bad. They felt very good during the waiting period after randomization to catheter ablation. So if they received catheter ablation, the results were almost same. So this was okay, but this is not okay. Very unhappy patients in medical group received catheter ablation. So this was a big limitation of the study. And as a result, in the ITT analysis, there was no significant difference between drug therapy and catheter ablation in primary endpoint. But considering the very high crossover between the group, they performed per protocol analysis at 12 months, and in this analysis, there was statistically significant difference between drug therapy and catheter ablation. So after this trial, a meta-analysis assessing the impact of AFib ablation on mortality, stroke, and heart failure hospitalization was published. And in all mortality, stroke, and the heart failure hospitalization, ablation was better than medical therapy. And when looking at the number needed to treat during 3.5 years, to save one patient from death, the number need to treat was only 28, a very surprisingly low number. So after this, EAST-AF-NET trial was published. Nearly 300,000 patients diagnosed within 1 year as AFib was enrolled. The mean age was 70 years old, and the first AFib episode, 37%, paroxysmal AFib 35%, persistence only 27%. Surprisingly, asymptomatic patients were included, 30%. And when you look at the treatment, initial treatment, mostly antiarrhythmic drugs, ablation only 8%. And at 2 years, ablation becomes increased to 20%, but dominantly antiarrhythmic drug is mainly used. In the rate control group, rhythm control was not performed at the baseline and also at 2 years. And median follow-up was 5.1 years. And as a result, early rhythm control was associated with significantly lower risk of CV death, cardiovascular death, ischemic stroke, heart failure, hospitalization, and acute coronary syndrome. The hazard ratio was 0.79, and looking at death from cardiac causes, it was significantly lower than rate control. And looking at stroke, it was significantly lower than control, rate control. And also when we see sinus rhythm, you can see very high sinus rhythm maintenance rate, 82.1% in early rhythm control as compared with usual care, 60.5% in usual care group. So this is very famous AFFIRM trial published 20 years ago. And in this trial, although not significant, there was a trend toward higher mortality in rhythm control group. But in this trial, the age was almost same in this EAST-AF-NET trial, but AF lasting more than 2 days was 70%. That means most of the patients had persistent AFib. And as you know, rhythm control using antiarrhythmic drug for persistent AFib is very, very difficult. So I don't think rate control is better than rhythm control. So after EAST-AF-NET trial, Korean nationwide study was published in BMJ, and they divided patient from diagnosis to treatment time within 1 year and over 1 year, early versus late. And in each group, they compared rhythm control versus rate control. And this is rhythm control, early rhythm control, and late rhythm control. In early group, most of the treatment was antiarrhythmic drugs. Ablation was only performed in this 1% or so. But in late rhythm control group, catheter ablation was performed in 19.6% of the group. And but also in this late group, dominant treatment was antiarrhythmic drug use. And as a result, in early AF group, rhythm control, early rhythm control was associated with significantly lower risk of CV death, ischemic stroke, heart failure, hospitalization, and AMI. But in late AFib group, there was no difference between rhythm control and rate control. Same thing is has been already reported in the field of afibrillation, and as you can see, duration diagnosis to ablation time within 1 year is very, very important. It is associated with higher arrhythmia-free survival, and we also reported this after the first procedure. Diagnosis to ablation time within 1 year is very important. But even after second procedure, within 3 years, that is okay. But after, if the diagnosis to ablation time is longer than 3 years, the long-term outcomes after the second procedure is worse than those with that within 3 years. So today's take-home message is catheter ablation of AFib is increasingly performed as curative therapy of AFib. In the current guidelines and consensus documents, catheter ablation for paroxysmal AF in symptomatic patients is class 1 indication as a second-line therapy. That is after antiarrhythmic drug use. And class 2A indication as a first-line therapy without the use of antiarrhythmic drugs. For symptomatic persistent AFib, catheter ablation is class 2A indication reasonable. Advances in the 3D mapping system and the ablation catheter have markedly improved the acute and midterm outcomes of AFib ablation. Cryoballoon is feasible and associated with shorter procedure time and lower influence of operator experience. Upcoming pulse field ablation is expected to reduce the risk of injury of nearby tissues and organs such as esophagus, phrenic nerve, and vagal nerves, and artery blood flow. AFib ablation for patients with concomitant heart failure is associated with improvement in all cardiac functions. Among low EF patients, persistent AFib, normal LV size, successfully maintained sinus rhythm are the independent predictors of subsequent improvement in LVEF. Several observational studies and 2 RCTs, Castle AF and Kavanaugh study, strongly suggested that AF ablation has a mortality benefit and reduce the risks of stroke and heart failure hospitalization. Thank you very much for your attention.
Thank you very much, Professor Satoshi, for your excellent presentation. I'll give the room to the panel for some questions. Professor Centurion, Dr. Benitez, Dr. Zapatini. Can you hear me?
Yes. If I may, I can start.
Sure.
That was a great exposition. Congratulations, Dr. Alderete and Dr. Shizuta. Very, very nicely done.
Thank you.
And the thing about atrial fibrillation is that it's a condition that when you
It's freezing?
I think it's freezing.
Anticoagulation, the problems involved with anticoagulations, like the bleeding problems and interactions with other medications, and the patient still feels symptoms of atrial fibrillation. They still feel palpitations, they still feel shortness of breath.
Mm-hmm.
And another option would be to put them into antiarrhythmic drugs.
Mm-hmm.
But they do work only in about half of the patients. Mm-hmm. And if they work, there are a couple of problems involved with them, like they can slow your pulse down, and even they have side effects, systemic side effects, potentially fatal side effects. Mm-hmm. And then comes the catheter ablation that comes up as a curative therapy that is better and better in time. and in terms of efficacy and safety.
Yeah.
Well, and I have a couple of questions. I would like to start with a question for Dr. Alderete. And I'm going to put it as a clinical case because this is the way that we usually face these kind of problems here in hospital. And let's suppose a patient about 70 years old, with high blood pressure, that undergoes a surgery. And after the surgery, he develops atrial fibrillation. And you begin to treat it with amiodarone, and it reverts to sinus rhythm. You even perform a 24-hour Holter monitor, and do I anticoagulate him for life?
Dr. Sabatini, you freeze for a moment and I couldn't hear your question. So please, if you can.
I'm sorry.
Again.
Well, suppose a patient, 70-year-old patient with high blood pressure that undergoes a surgery, an abdominal surgery, and after surgery he develops atrial fibrillation that reverts with amiodarone. But he has a CHA2DS2-VASc score, a high CHA2DS2-VASc score, over 4. But he has a potential cause that would be the surgery. And considering this, do I anticoagulate him for life, having in mind only the CHA2DS2-VASc score?
Yeah, I think that situation is not uncommon. So many patients can develop atrial fibrillation after an acute illness, acute myocardial infarction, surgery. So I think we have to take into account the risk of the patient and the ejection fraction, how long is this episode of atrial fibrillation? This is a very short atrial fibrillation, is a long atrial fibrillation. The patient probably after a surgery will be admitted into the hospital for about a week, so we can see if the patient has all the week after the surgery atrial fibrillation. So probably that patient has atrial fibrillation and have never been diagnosed before the surgery. So I think this is a case-by-case decision. So we have to take into account many things: the duration of the atrial fibrillation, the risk factors of the patient for bleeding and also for stroke and embolism, and take the decision according to it. So probably if the patient had a high CHA2DS2-VASc score, I will anticoagulate the patient and follow up the patient and see with Holter or long-term monitoring if the patient persists with more atrial fibrillation, so we'll continue taking oral anticoagulants. Or in the case that the patient in the long-term follow-up never develops again atrial fibrillation, probably we should evaluate to withdraw the oral anticoagulation. So, but it's a case-by-case decision.
Yes, excellent.
Thank you, Dr. Jose. Dr. Benitez, you have a question? Are you there?
Yes, hello, how are you? Very nice presentation for both of us. For both of you, I want to know which one of the two techniques of atrial fibrillation ablation would be more feasible from the economic point of view for a country like us, because I think that one of the cryoablation is more cheaper than the radiofrequency ablation because of the cost of the navigator system. So which one we have to choose to develop here in our country?
Thank you very much. It's very, very important question, I think. And but unfortunately, I'm not. I don't know so much about the cost of the cryoballoon compared with the radio frequency catheter elevation navigated by 3D mapping system worldwide, because it is different from country to country. In Japan, cryoballoon is not so expensive, so probably cryoballoon is cheaper than RFCA, radio frequency catheter ablation using 3D mapping system. But if cryoballoon, the price of cryoballoon is set to be cheaper than usual RFCA using 3D mapping system, it is not happy for companies of RFCAs. So I heard that in many countries, including US and Europe, the price of the cryoballoon is set as a little bit higher than Japan and a little bit higher than average cost of RFCA AFib ablation. So it is highly political. So of course, after Dr. Jose completely learned the AFib ablation in Spain, of course we taught him a little bit, but after he mastered AFib ablation, ideally it is best that he can do both RFCA and cryoballoon, but it's highly political problem. So you should, I think, Paraguayan doctors should negotiate to the company regarding the cost of the cryoballoon, and also regarding the cost of the RFCA and 3D mapping system. It can be, cryoballoon can be cheaper than RFCA and it can be higher than RFCA. It differs from country to country. In Japan, probably cryoballoon is cheaper than RFCA.
Thank you.
But not only the cost. Which do you choose? That is a very, very good question. But cryoballoon is very feasible. The procedure time is shorter, and the long-term success rate is similar. But if the RFCA operator has excellent skills, maybe the long-term outcomes becomes better in RFCA. So it depends on the operator's skill in RFCA. And also recent topics is not only pulmonary vein isolation, but also to eliminate extra PV foci, including SVCs and other sites. But cryoballoon cannot isolate SVC because SVC, in SVC isolation, there is a sinus node nearby SVC, and also there is a phrenic nerve, right side phrenic nerve, very near to the SVC. So we cannot use a cryoballoon for SVC isolation. In SVC isolation, we carefully burn using RFCA. So if a patient has active firing from SVC, we cannot cure the patient's AFib using cryoballoon alone. That is a problem. But in such situation, we can finish the first session just isolating pulmonary vein. And if patient has continuously has AFib problem, then we can perform second session. And at that time, you should use RFCA. So choosing only one is probably not enough to perform AFib evaluation in one country. So I understand that you would like to change cheaper one, but RFCA and cryoballoon is not equal. And also cryoballoon the size of the cryoballoon is 28 millimeter. When the LA becomes larger, especially in the setting of a persistent AFib, the diameter of pulmonary vein becomes larger. So when it the diameter of pulmonary vein becomes larger than 26 or 7 millimeter, we never use cryoballoon because it can go easily into the pulmonary vein. And so it leads to pulmonary vein stenosis. And when you burn inside deeply inside the pulmonary veins, many arrhythmogenic forces outside the isolated line will cause residual atrial fibrillation. So cryoballoon can be used only for patients with, mainly for paroxysmal AFib patients with relatively small left atrium and pulmonary veins with small diameter, smaller than 25 millimeter. So considering that, when studying AFib ablation in Paraguay, I think RFCA and cryoballoon both is necessary, I think.
Okay, thank you for your response.
Thank you, Professor Satoshi. I have a question from the audience. He is Dr. Raul Torres from the UT Health East Texas Heart and Vascular Institute from the USA.
Yeah.
And he's asking, what is the number of cases a year you suggest would give minimal expertise for safely conduct an AFib program?
You mean in the field of PCI, number of cases of 100 is necessary to keep the level of the procedure like same? You think there is such kind of number of ablation? That is the question, to keep the quality of the procedure. So minimum number of AFib ablation, I think. I'm not sure, but at least 50, ideally 100. Yeah.
Yeah, ideally. Okay. Another point, do you mainly use ICE or intracardial echo or flow for the ablation?
I personally, in Japan, we can use many things, and restriction of the is not so strong. So especially in university or hospital, we can use many things, but I use echo just for transeptal puncture. I don't use echo for burning the pulmonary veins. Some operators love to use echo, partly to reduce the radiation dose of fluoroscopy time. But using 3D mapping system, echocardiography is not so important, I think. So fluoroscopy time is 20 minutes or so. So radiation dose is not so much. So I personally don't use echo, just use echo for transeptal puncture.
Okay, and regarding the endpoint, you consider which one is better, the symptom-free or arrhythmia-free, to consider the success of the atrial fibrillation ablation?
Of course, arrhythmia-free. Because symptom-free but AFib, then in such situation, patients should continue to receive oral anticoagulation. And so symptom-free is not good. If patients is symptomatic patients, and if patients have relapse of AFib in Holter monitoring or ECGs at periodical visit in outpatient clinic, most patients should have symptoms. And if the patient have no symptoms, maybe rate control eliminated his symptoms, but it's just rate control therapy. So rate control better or rhythm control by catheter ablation better? Many studies and recent data suggest that rhythm control by catheter ablation is much better than rate control. That is recent data. So if patients feel no symptom, but AF is still recorded, it's not a good situation, I think. So arrhythmia-free is the goal of the treatment.
Yeah.
Okay.
Yeah. Thank you. And one last question. After successful ablation, do you stop anticoagulation if the patient has a chest vasc more than 2?
Yes, yes. But in patient chest vasc 2, or chest score 2, but when patient has previous stroke, chest vasc score becomes at least 2. And when patient has hypertension, diabetes, the patient chest vasc, also becomes 2. But it's I don't think it's same 2. I think patients with prior ischemic stroke has higher risk as compared with such chest vasc 2 patients with hypertension and diabetes. So usually I will not stop oral anticoagulation in patients with prior history of ischemic stroke. And in other type of patients with chest vasc score equal or more than 2, I stop oral anticoagulation. But talking and consulting with patients, and I tell the patient, continuing oral anticoagulation has advantage that there is a low risk of ischemic stroke even if asymptomatic AFib occurred, but it is associated with high risk of bleeding. And discontinuation of oral anticoagulation is associated with low risk of bleeding, but maybe although you are symptomatic originally, when you become old, the relapse AFib is often asymptomatic. So in such situation, it will associate aided with stroke and relatively high possibility. So which do you choose, I think? But also in such situation, Japanese patients ask me, which do you think is better? So I have to say to the patient, and I have to, in such situation, I tell the patient, your Holter monitoring is very good. So I think I recommend you to discontinue oral anticoagulation. So I take oral Holter monitoring 3 months, 6 months, and 12 months, and yearly thereafter. And if Holter monitoring is very, very okay, I recommend the patient to discontinue oral anticoagulation. The cutoff line is PAC less than 500 per day. 500 per day.
Yeah.
Ideally 100 per day. 500 is maybe too high. There are reports showing that patients with PAC higher than 1% frequency is associated with higher risk of subsequent AF relapse. So I will never recommend OSC discontinuation in patients with PAC more frequent than 1%.
Okay, thank you very much, Professor Satoshi. Professor Centurion, some other question?
Yeah, I enjoy very much your talk, Satoshi Sensei. You brought us 20 years of experience with atrial fibrillation. I was wondering, when you finish your AF ablation, isolating the pulmonary veins, you see that you have the 4 pulmonary veins nicely isolated. When do you perform additional lines of ablation, for example, at the roof or in some other parts of the atrium? When do you perform additional lines, and how often do you do that?
Thank you very much. It is very important questions, and yeah. For paroxysmal AFib patients, I usually not perform additional LA ablation after PV isolation because roof line is not so difficult, but mitral essence line is not so difficult, but it is a little bit challenging and it will take time, and the rate of recurrence is high. And making incomplete line will lead to high possibility of the risk of iatrogenic atrial tachycardia, rotating just the over the line when you burn the mitral essence line. If it is complete, patients often come back to hospital with mitral atrial tachycardia. So I only add left atrial linear ablation or some additional ablation when patient's type of AF is persistent or long-lasting persistent, and also in such patient, non-paroxysmal AFib patients, after PV isolation, I perform voltage mapping all around, so I map all the LA, including PV, confirming there is no potential alcohol in PVs, and also calculate the voltage of the entire LA. And if there are many low voltage area, I burn low voltage area, and also probably sometimes I often make roof line in such patients, but not mitral line usually, because usually low voltage area is located at anterior wall, and when you burn aggressively at the anterior wall, and when you burn mitral essence line that is located posterior side of the left atrial appendage between LIPV and mitral annulus, when you burn there, then left atrial appendage will be isolated. So I don't want that. Although we have Watchman devices, left atrial appendage closure devices, but I don't want to do too much in the first ablation for such kind of patient. So I will never make mitral essence line in such kind of patients. Yeah, just roof line and low voltage area ablation. And recently, fractionated area ablation, not cafe, but fractionated during sinus rhythm. In such an area is very arrhythmogenic. So sometimes I will burn those areas. In paroxysmal AFib patients, I rarely perform LA additional ablation. Too much is not good.
What about substrate ablation in those? What about substrate ablation in those persistent? Yeah, in those patients with persistent AF. Substrate ablation, I mean, when you ablate those zones that have very low bipolar voltages.
Yeah. I burn so when the low voltage area is huge in LA, I make the mitral block line at the anterior side, not posterior side. So burn all the low voltage area, but before burn all inside the low voltage area, I burn with high energy and make a linear line from the anterior mitral annulus to RSPV, long mitral anterior line. When those areas are all low voltage areas, I don't want a healthy myocardium. So when the anterior walls are largely damaged and largely low voltage area, I create the low voltage, my anterior isthmus line in that low voltage area. And thereafter, I bond all around the homogenization bond inside the low voltage area all around. Yeah. What is important is make complete line. It is very, very important. Yeah.
Thank you.
Thank you very much.
Thank you.
So, again for your time, taking your time. We know this is very late night now in Japan, and we enjoy very much your conference as well as Dr. Alderete. And I'm very pleased to hear from you that he is doing a great job, because he was graduated from our school, and we are very proud of him working with you, Professor Satoshi, and hope to have you again soon in this kind of meeting, and hopefully in person in the coming month. Thank you very much, Professor, and thank you very much, Jose, and all the panels for participating in this international meeting.
Thank you. Thank you so much.
Okay. Bye-bye.
Bye-bye.
Some other questions? Bye-bye. Thank you.
Rei potaro e gerurente, peisajina Paraguay, paipuque la Emiliano, ta ipuque la Yambay, yajamino ñondive, yero que hape, torbe ape, yaje shape koe, aguille manteame, agüeruco señe, toiko subi pura hey, albu arito bebé. Aguille manteame, agüeruco señe, rico subi pura hey, algo arito bebé, aguille manteame.
Ya sea cuaracu, todo aveima, o cañimboracu, doye veima, tapere, de hueca tunde que, te quiere o yo quiere, ya jamón.
Subi pura hey, algo